was astounded by the results. I was even more astounded by local data. What you are seeing is a map of New York City neighborhoods and their different life risk outcomes. Life risk was the summation of factors such as poor education, lack of housing security, poor health outcomes, and others. It's incredible that the highest risk neighborhoods and the lowest risk neighborhoods are less than a mile away. Even more surprising is how neighborhood risk changes depending on the risk factor. If we look at health outcomes, the highest risk neighborhood changes to Brownsville. This data also shows a racial disparity, and that high-risk neighborhoods are predominantly Black and Latinx, while low-risk neighborhoods are predominantly white. This is all true if we look at other risk factors, like poor youth outcomes. So what can social workers do? First, we need to change our approach to health. The predominant model in the healthcare system is the medical model that looks at health as the absence of illness. The biopsychosocial model, however, shows that there's a multitude of factors outside of the individual's control that affect health. The ACEs study was able to give empirical evidence of the biopsychosocial model. Negative external factors in childhood greatly increase the risk of negative health outcomes in adulthood. The second step involves developing more integrated partnerships. The current decision-making hierarchy places individuals and communities last. Social workers need to advocate for a system that places individuals and their communities at the center of care. Third, NYU's free clinic model, which provides free primary care, cannot rest downtown. It needs to go out to the communities that need care. Teams led by social workers that can then customize care and reduce transportation barriers. Third, statewide, 71% of parents feel that their child was not treated in an effective healthcare system. Free clinic teams can address this by not only offering preventative care services, but also offering care programs for youth ages 12 to 17 that need help transitioning from their pediatrician to their adult care. Steps 1, 2, and 3 are tied together by utilizing technology. Online care increases access to services for low-risk patients, which then decreases wait lists for high-risk patients. 90% of children in the U.S. see a pediatrician. 67% of pediatricians feel like they do not have sufficient training in assessing and treating mental health disorders. Online, social workers can provide culturally congruent and evidence-based trainings. We can also use tech to collect data about this gap. These are just some questions that multidisciplinary research teams can answer. We can be the change makers for healthy future generations. Thank you.
Do we have questions from the judges for our final presenter?
Can you hear me?
Yes.
I really like how you put the social before the health as a driver of more health outcomes. So it's a total reframe of our healthcare system.
Yeah.
So that's really interesting, and of course that's what we do as social workers. So one of the ways you suggested we can take better hold of that is by what you called integrated health partnerships. And I'm just wondering if you can talk a little bit more what you're thinking about that.
Yes, I think first of all, we need more data from communities and the citizens in each of these neighborhoods in and of themselves to assess what specific needs that they have. So right now, data, we don't know the prevalence of mental health symptoms in children per neighborhood. We don't know specific barriers to treatment, so we need further data on that, first of all. I'm thinking of a project actually right now at NYU Silver called the Safe Mothers, Safe Children's Project. I actually worked closely with that project, and basically the model was giving this treatment and sending the clinicians out into localized communities to provide the care, but also working with the agencies that are already there. These workers already know the issues and the needs of these communities. So utilizing their knowledge, and allowing us to be more facilitators, allowing them to use our resources so we can give back. So it changes the model from, okay, I'm telling you how to do this, versus let me see what you need and let me provide the resources for you. So that's already being done, and I'm advocating for something to be pushed further.
Are you familiar with the Thrive Project in New York City? Do you see some way to link this to this effort? Can you be a little more specific on that?
Yeah. So similarly to community partnerships, we can also advocate on the macro level. for these kind of changes to happen. And I think on the macro level, if you change the mindset of legislation and this idea of health being a biopsychosocial model, and that there are other factors that I didn't talk about here, like discrimination and racism, how do these affect health outcomes as well? I think it could change the mind of the policymakers and then change the policy. And if they have data that's showing that it's effective, I think that backs up, further policy even more.
Thank you so much for your thoughtful questions.